Hi, I'm Joe Graydon.
And I'm Terry Graydon. This podcast of the People's Pharmacy is brought to you by Squatty Potty Toilet Stools. They create healthy toilet posture for fast, easy elimination. Learn more about toilet posture and health at squattypotty.com. That's SQUATTYPOTTY.com.
100 million Americans suffer chronic pain. Current treatments are often inadequate. Is there anything that can give them relief? This is the People's Pharmacy with Terry and Joe Graydon.
The media has directed a lot of attention to opioid abuse and the epidemic of overdose deaths that result from prescription medications like oxycodone, as well as illegal drugs such as heroin. There's been far less interest in the dilemma of people who suffer chronic pain and have great difficulty finding respite from their agony.
Are there other options to controlling chronic pain besides NSAIDs and narcotics?
Coming up on the People's Pharmacy, we explore a nation in pain, healing our biggest health problem.
First, the news.
In the People's Pharmacy Health Headlines, the U.S. Centers for Disease Control and Prevention are warning pregnant Americans not to travel to Caribbean and South American regions where mosquitoes carry Zika virus. In addition to Puerto Rico, the alert warns about travel to Brazil, Colombia, El Salvador, Guatemala, Haiti, Honduras, Mexico, Panama, Suriname, Venezuela, and a few other countries. There's no vaccine or treatment for Zika virus, which can cause rash, fever, and joint pain. The main concern with Zika virus is that it can cause birth defects in babies exposed in utero. There have been 3,500 cases of microcephaly detected among Brazilian babies. The virus may interfere with development of the brain and skull, leading to babies with abnormally small heads. Many do not survive. There are now several cases in the U.S. linked to pregnant women traveling to areas where the virus is prevalent.
The ticks that carry Lyme disease are becoming ubiquitous throughout the United States. According to the CDC, they're now found in nearly 50% of U.S. counties. That's up from 30% in 1998. Lyme disease is caused by bacteria called Borrelia burgdorferi and can cause fever, headache, fatigue, and joint pain. If the infection is not treated promptly, it can become a chronic condition with neurological symptoms such as numbness, pain, or tingling in the hands and feet, along with cognitive difficulties. Muscles, bones, and tendons may also be affected. Some people develop irregular heartbeats or damage to the heart muscle. As this tick-borne disease continues to spread, people will need to become more vigilant about checking for ticks and reporting bites and symptoms to their healthcare providers.
Most people's hearts beat between 60 and 80 times a minute when they're not doing anything strenuous. But a new study published in JAMA Internal Medicine shows that naturally slower heart rates in the 40s or 50s don't mean a higher risk of cardiovascular complications. A slow heart rate of under 50 beats per minute may cause unpleasant symptoms such as dizziness, fainting, shortness of breath, or even chest pain. A 10-year study of more than 6,000 middle-aged and older adults found that such a slow heart rate was not associated with more heart disease. There is one important caveat. People whose heart rates were slowed by medication were at higher risk of death. A rapid heart rate over 80 beats per minute was also associated with higher mortality in this group. The researchers were not able to tell whether this was due to the underlying disease requiring treatment or to the drugs used.
If you use weekends to catch up on sleep, you may be able to avoid the higher risk of diabetes associated with chronic sleep deprivation. A small study of 19 healthy young men showed that after 4 days of sleep deprivation, they had lower insulin sensitivity and were less able to control blood sugar levels. Testing after 2 days in which they caught up on their sleep showed a quick recovery to normal levels of insulin sensitivity. During each catch-up night, the men snoozed almost 10 hours on average. The study shows that even short-term sleep loss has negative metabolic consequences, but this can be reversed so long as the lack of sleep is not sustained for too long. The scientists point out that the participants in the study were young, healthy, and lean. No one knows if people with prediabetes or metabolic syndrome would react in the same way.
One of the more popular prescription sleeping pills has been Zolpidem, sold under the brand name Ambien. Although most people think that the effects of this sleep aid have worn off by the time they get going the next day, a new study of older drivers suggests otherwise. Researchers tracked the records of 2,000 older people in Alabama. Women over 70 were about 60% more likely to have been involved in a car crash if they were taking Zolpidem. Drivers over 80 were more than twice as likely to be in an automobile accident if they were taking this sleeping pill. The take-home message seems to be that older people, especially women and those over 80, should not drive if they've taken a sleep medication like Zolpidem the night before. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Have you ever stubbed your toe or hit your thumb with a hammer? The pain is instantaneous and excruciating. But unless you break something, it tends to fade after a while. Before long, you'll probably forget the entire incident. But what happens when pain doesn't go away?
To find out about the challenges of chronic pain, we turn to Judy Foreman. She's a nationally syndicated health columnist who spent 23 years as a staff writer for the Boston Globe and has also written for the Los Angeles Times, the Dallas Morning News, and numerous other papers. She's a senior fellow at the Schuster Institute for Investigative Journalism at Brandeis and author of A Nation in Pain, Healing Our Biggest Health Problem.
Welcome to the People's Pharmacy, Judy Foreman.
Thank you very much. I'm glad to be here.
Judy, your first book was titled A Nation in Pain, Healing Our Biggest Health Problem. And I just wonder, since that book was published, how bad is it?
There are a lot of people in pain, roughly 100 million, and that number is not picked out of thin air. It comes from the Institute of Medicine, which had a high blue ribbon level committee that came out with a report in 2011, and it did find 100 million Americans suffering with chronic pain. Now, they're not all like bedridden. About 10 to 30% have really severe, disabling, life-wrecking pain. The rest have milder levels of pain. But when you put them all together, there are more people living with chronic pain than have diabetes, cancer, and heart disease all put together. So it really is the nation's biggest health problem.
Well, there are several different kinds of pain. Can you tell us about them, please?
Yes, there's actually many different types of pain. Just for the record, the official definition of pain, which comes from the International Association for the Study of Pain, which is an academic group of about 7,000 or 8,000 neuroscientists and other scientists, that definition is that pain is an unpleasant sensory and emotional, that's important, experience associated with actual or potential tissue damage or described in terms of such damage. So it is both a sensory experience and an emotional experience. There's no way to have severe pain and not have the limbic system of your brain light up. It is intrinsically emotional as well as sensory. Acute pain, we all know, after surgery or a broken arm or whatever, that sort of goes away fairly quickly. Chronic pain is what I'm talking about in the book, and that is what the 100 million Americans have. It's not just pain that lasts for 3 to 6 months, although that's the quickie definition. And it's not just acute pain that doesn't go away. Chronic pain is actually a transformation of the nervous system so that, it's kind of like a freight train that gets revved up faster and faster. The nervous system gets better and better and better at processing pain signals from the periphery up through the central nervous system to the point where the initial trigger, the initial insult or injury or problem doesn't even have to exist anymore. The nervous system just gets in a loop, an endless loop by itself. And that's important because that means that chronic pain becomes a disease in its own right, a disease of the nervous system, not just a symptom of something else. In terms of the different categories of pain, there's like several different types. There's nociceptive pain, the kind you get when you hit your thumb with a hammer. There's inflammatory pain. That's like arthritis, or, I mean, you could even call any kind of chronic inflammation inflammatory pain. And that can be severe and takes a long time to go away. There's another kind of pain that people call dysfunctional, although you could argue that all pain is kind of dysfunctional. That's like fibromyalgia, irritable bowel. There's no obvious thing or stimulus causing that pain, but it has effects anyway. And then in some ways, the worst category of pain, not to minimize the others, but the worst in a way is neuropathic pain, which just means damage to the nervous system itself. It's very long term and it's horrific, basically. And, the different types of pain sometimes respond better to one treatment than another. So you kind of have to figure out what kind of pain it is.
Well, we have heard that health professionals will often ask a patient, rate your pain on a scale of 1 to 10. 10 being the worst pain you've ever experienced, 1 being, fairly mild.
That's right.
It seems to me, and again, I'm not a pain expert, that trying to use that scale for all of these different kinds of pain may be a little simplistic.
It is simplistic, and people get kind of annoyed by being told that. Although I have to say, I think it's progress that now hospitals in general are required to ask you how your pain is. I mean, that didn't used to be the case. So at least if your doctor asks you, that they're taking your pain somewhat seriously. But you're right. It's a very crude scale. I think we're heading in a better direction ultimately with brain scans like functional magnetic resonance imaging, fMRIs, which can sort of help tease apart the severity and the location of the pain, but those are not really available to every patient who goes to the doctor now. They're still basically research and experimental tools. So in a way, this verbal or pictorial, for kids, they use, faces of a face grimacing and a face smiling and all along the continuum in between. And there's visual analog scales are slightly more sophisticated, but basically the thing is we are, as patients, asked to self-report, to tell the doctor in words or by pointing to pictures how bad our pain is. And that's an intrinsic problem because it depends, if you're my doctor, on my trying to describe to you in mere words a sort of a very nonverbal experience. And it means you as the doctor have to rely on what I'm telling you. And that makes it, it's very subjective, and there's no external objective test that can confirm to you and allay your suspicions and tell you that I really am having a lot of pain. And that's a huge problem with people being dismissed by their doctors.
Well, you hit the nail on the head, that suspicion thing, because there are a lot of health professionals who think, oh, this patient is just malingering, or this patient is abusing drugs. And I don't really believe him or her when he says, yes, my pain level is an 8. He doesn't deserve a powerful pain reliever. I think his pain is really only a 2 or a 3. And it's a subjective thing, and, we have no way of measuring it.
Well, frankly, I would have believed that myself until it happened to me. I mean, I'm a science writer, and I thought, oh God, people in pain are just wusses. They're making it up, or they're exaggerating, or they're just depressed or anxious, or, kind of get a life. And then it happened to me. And in my case, it was fairly sudden onset, severe neck pain. And there was no way I was making that up or exaggerating it. It was really real. But it is so subjective that, if I hadn't experienced it myself, I wouldn't have believed that kind of pain was possible. Because evolutionarily, why would it be there? It serves no purpose. It didn't teach me to avoid lions or fires or, any dangerous thing. It was completely non-functional. And yet there it was. And I wouldn't have believed it unless it happened to me. So I'm sympathetic to doctors, especially young doctors who probably haven't had that much pain, not believing their patients, but they should.
Was there ever any diagnosis to explain the source of the pain?
Yes, and in that sense, I was luckier than a lot of pain patients who never, a lot of times doctors and the patients themselves never really figure out what the problem is. In my case, I had what's called spondylolisthesis. It's a long, complicated word, but it means your vertebrae, and in my case, in my neck, were sliding forward over each other. They didn't quite get to the point of compressing my spinal cord, but they were close. I did have some bulging discs, and I had radiculopathy. My nerve roots in my neck were irritated and inflamed, and it felt like just a straight shot of pain going from sort of the middle of my neck down to the tip of my left shoulder, where it completely stopped. I had no tingling or numbness or anything down my arm, as some people do. But that constant nerve stimulation had a secondary effect, which was to stimulate my trapezius muscles all the time so that they were spasming to the point where I wound up with what's called cervical dystonia. The spasming muscles tipped my head so far to the left that I had to use both hands on my cheeks, on my face, to get my head back upright. So it was a mess. And I also had bone spurs. And so the slightest little motion, like picking up a pencil off the floor, or I had a radio talk show myself, and I'm wearing headphones like I am right now with you, and having the headphones on my head, which don't weigh very much, just having that for an hour was excruciating.
What did you do to alleviate that pain?
I did everything, which I also heartily recommend to people.
We only have a couple minutes, so maybe you can give us the executive summary.
Okay. I do recommend, drugs as the last resort, but not an option to be forgotten. But acupuncture, massage, therapy, psychotherapy, physical therapy. The thing that I think really cured me was exercise, which I already had been doing a lot of anyway. But I went to what we called boot camp, which was run by New England Baptist Hospital in Boston. And it was very intensive physical therapy. And they made me do exercises that I thought would leave me paralyzed, frankly, and they didn't. I got fixed. The whole revving up of the nervous system that happens with chronic pain seems to be unrevved by or desensitized by exercise. So exercise is the closest thing we have to a magic bullet, but it's hard to get people in pain to do it.
Well, of course, it's the last thing you want to do if you're in pain, because
exactly.
It's like, oh, that's going to make it much worse. And what you're saying is maybe it's one of the important tools in the toolkit so that we don't have to rely on the heavy-duty narcotics.
That's exactly right. And people in pain, including me, have what they call kinesiophobia, which is fear of movement. You're literally afraid that if you move, you'll cause tissue damage, or you'll make things much worse. I was afraid that my vertebrae would slice through my spinal cord in my neck. And it's very hard to get people to give up that fear. And the only way to really give it up is to sort of try it out with a physical therapist, watching your every move and discovering that you're not getting worse, you're getting better.
You're listening to Judy Foreman. Her book is A Nation in Pain, Healing Our Biggest Health Problem.
After the break, we'll talk about the drugs people use to ease their pain.
How do chronic pain patients find alternative approaches?
The stigma associated with narcotics means that some people in chronic pain may be unable to get them or afraid to use them. How do the DEA's rule changes affect people in pain?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. The number is 800-345-5858. 800-733-7339. The website is uttercream.com.
And by Squatty Potty, the original toilet footstool that creates healthy toilet posture. You can learn how squatting relaxes the colon and allows for easier, healthier elimination at squattypotty.com.
If you'd like to order a CD of this show, you can call 800-732-2334. Today's show is 1021. That number again, 800-732-2334, or visit our website, peoplespharmacy.com.
Today on the People's Pharmacy, we're talking about chronic pain and what can be done about it. Our guest is Judy Foreman. She's a nationally syndicated health columnist who spent 23 years as a staff writer for the Boston Globe. She's also written for the Los Angeles Times, the Dallas Morning News, and other papers. She's a senior fellow at the Schuster Institute for Investigative Journalism at Brandeis. Her book is A Nation in Pain, Healing Our Biggest Health Problem.
Judy, we were just talking about your pain and how you got over it in large part thanks to exercise, but I think an awful lot of people, regardless of the pain, it may be a back that's acting up, it may be bursitis in an elbow, it may be a headache, it may be osteoarthritis of the knee, they turn first and foremost to nonsteroidal anti-inflammatory drugs, NSAIDs for short. Ibuprofen, naproxen, diclofenac. There are probably over a dozen of these drugs, some by prescription, now many over the counter. I'd like your perspective on these drugs, how well they work, and the downsides.
Yeah, that's a great question because, people sort of associate pain with the stronger opioid drugs, which I know we'll get to in a minute. But you're right. Most people, their first line of attack is the NSAIDs and acetaminophen. And that's a reasonable thing to do. But what people forget, because there hasn't been nearly enough publicity in my mind on this, is that NSAIDs can kill as well. In fact, the data is all over the place. The studies have been contradictory, but anywhere from about 7,000 to possibly 16,000 people a year die from taking the NSAIDs. And a lot of that is the GI, the gastrointestinal bleeding that can be very severe. A relative of mine had that, and you got totally anemic, and you can literally bleed to death. The other thing that's becoming more known now scientifically, there have been a number of studies in the last few years about the cardiac risks with NSAIDs. Aleve, and I just for the record take no money from anybody, especially drug companies, but no money from anybody. Aleve, the data seems to show that's naproxen. That seems to be less likely to cause cardiac risk than some of the others. But again, NSAIDs are great in low doses, but they can be really tough on people, and especially older people. Some older people have to turn to opioids because they can't tolerate the NSAIDs. Acetaminophen is another real cause for concern, although it also can be somewhat effective. There are about 30,000 hospitalizations a year because of acetaminophen, which everybody knows is the main ingredient in Tylenol. One of the problems is it's in a lot of other drugs as well. So you can be very unaware of how much acetaminophen you're actually taking into your body because it's in a lot of other things. It's not just in Tylenol. It can be very toxic to the liver. And one thing that's absolutely clear, and everybody agrees on, all the scientists, if you take, and the FDA, the Food and Drug Administration, if you take acetaminophen, you absolutely cannot drink alcohol because the risk of liver damage goes way, way, way up. So if you're going to take acetaminophen, you really have to steer clear of alcohol. Those drugs can work, and I started with that too, and I was taking pretty high doses of NSAIDs, and like other people, I developed high blood pressure temporarily. It went away as soon as I stopped, but none of these drugs is a free lunch, but they can help, and they're a good first step for many people.
And Then the next step would be?
The next step is to say, oh, help. Well, sooner or later, these steps lead to going to the doctor. In fact, chronic pain is the main reason people go to doctors, and it's the main reason Americans, are on disability. The problem with going to the doctor, and I certainly advise people to go to the doctor, is that doctors often don't know what to do. And I won't dwell on this, but it's a major kind of infrastructure problem. There was a big study from Johns Hopkins in 2011 that documented that over 4 years of medical school, doctors get only a median of 9 hours of education in pain. Veterinarians, by the way, get 87. So you're better off going to a veterinarian. I mean, that's facetious, but doctors don't really know what to do. They don't really know how to treat pain or differentiate the different kinds of pain. And they will often start people off on the NSAIDs or acetaminophen, which is a reasonable first course, but it's not the total answer to go to the doctor. And many pain patients with severe chronic pain end up going to multiple doctors. And it's not necessarily doctor shopping in the sort of pejorative sense. It's doctor shopping for someone who seems to know what they're doing and can actually help you.
Well, I suspect that there's also a lot of shopping for alternative approaches. So, someone who doesn't get the relief they would hope for from their physician or several physicians may then turn to the herbalist, the acupuncturist, the massage therapist. I mean, there are a lot of people just waiting to fill that void.
Oh, yeah. And I think it's great to turn to those. I wish the reimbursement system for medical care included more of that in this country, but absolutely, the evidence for acupuncture is getting stronger and stronger. Again, it's not a slam dunk, but if it can knock your pain down from a 10 to a 9, and then massage can knock it down to an 8, and exercise can knock it down to a 7, you can get a better handle on it. Massage works for a lot of musculoskeletal problems. It works especially well if you combine it with exercise or physical therapy. Chiropractic is very, very popular. It's one of the most popular forms of alternative medicine. People swear by it. The evidence is mixed because many of the studies also include exercise. So it's a little bit muddy trying to figure out what's doing what. But yes, I heartily recommend those things. And some of the mind-body techniques, meditation.
We're going to come back to the meditation issues and the mind-body, but I want to go back to your doctor issues first.
Okay.
Because you said, the first place that most people go when they're in real pain, when the pain is in that 6, 7, 8 range, or when it's chronic, they're going to their doctor. And they may go to several doctors. And when the doctor reaches, the end of the line with, the kinds of drugs we've been talking about, acetaminophen, NSAIDs, out come the heavy guns, out come the opioids. Now, the opioids have taken a lot of bad publicity over the course of the last couple of years. I mean, just looking at the headlines in the last few weeks, we see that opioid addiction is a fast-growing threat both in New Jersey and across the country. Toll of lives lost and families left bereft are climbing. Another headline says, an act concerning substance abuse and opioid overdose prevention is intended to limit overdose deaths. I mean, on and on. 26 million people abusing opioids around the world. So we're told that while opioids have a place, they're really, really dangerous.
And they call that opiophobia, which scientists in the field sort of define as an excessive fear of opioids. Opioids are certainly like the big guns and to be avoided if the little guns work and all the alternative remedies. They are much more dangerous in the hands of mainly young people who take them for non-medical reasons, i.e. to get high. They are much less dangerous in the hands of pain patients who tend to be older and, if anything, to underdose themselves and use the drugs only for medical reasons. I mean, the differences are quite profound. It's almost like there's two different populations of people using these. The actual figures, the latest figures from CDC, which is the Centers for Disease Control, are that in 2013, 16,000 16,235 people died in they call it opioid-related deaths. An interesting thing to note about that is only about a quarter, only 27% of those deaths involved opioids alone. A lot of times people also take benzodiazepines or alcohol or marijuana with it, and yet opioids get all the blame. They get all the headlines. And I think that's partly a journalistic problem because the press, of which I'm a member, tends to play up the dramatic opioid deaths and totally ignore, including the deaths from suicide, but the miserable lives of people in pain. There's some pain physicians who estimate that perhaps as many as 16,000 people with chronic pain commit suicide every year. That number is totally squishy and we can't really rely on it, but we know that the suicide rate for people with chronic pain is twice that for people without pain, and we know that there's roughly 32,000 suicides every year. So you could inferentially guess that a lot of people in chronic pain are committing suicide. So it's not just that the opioids are bad, it's the underlying reasons that people are taking them and taking them irresponsibly. And a lot of those people have a genuine addiction problem and genuine mental health problems. So it gets very complex, and all those things have to be addressed.
Well, I wonder if the media's focus on the opioid problem, the deaths from opioids, and particularly the fact that they're being used for, as you put it, non-medical purposes, has stigmatized narcotics to the point where people who actually do have chronic pain are not able to get them, or perhaps are afraid to use them.
That is so completely right. And it reminds me, I gave a talk a couple of years ago at Memorial Sloan Kettering Cancer Center in New York, and I met with a bunch of palliative care fellows after my talk, and they were saying that even among their patients who were dying, some of those patients did not want to take opioids, which are narcotics, out of the fear of becoming addicted, which, when you're a few weeks from death is totally irrelevant, and the stigma. Here are people who could have been helped by getting pain relief in their last days, and they were afraid to take the drugs.
Judy, as a pharmacologist, I remember we used to make a distinction between addiction and dependence, and we've been chastised for doing that in recent years. Can you clarify what the difference is?
Yes, I mean, a handful, I would say, of pain specialists think that it's a distinction without a difference, but the vast majority say the distinction is a distinction with a difference. The definition of addiction is that it is a primary chronic neurobiological condition characterized by impaired control over drug use, compulsive use, continued use despite harm, craving, and often it does involve committing crimes to get the drugs. It's really a loss of control completely over the use of the drug. Physical dependence is different. It's a state of adaptation by the body that means that you will go through withdrawal if you stop taking it, and the withdrawal is no fun, but it's a different animal. If you take opioids for a couple of weeks, there's 100% chance that you'll become dependent physically, which means that you have to taper off slowly, and sometimes you have to use other drugs to taper off. It's not necessarily a bad thing. There are people who take opioid-containing drugs for decades without upping their doses or misusing them in any way. Addiction is a much more serious problem, but also much, much, much rarer. The true rate of addiction is hard to figure out. People argue about it all the time. It's probably somewhere between 3 and 30% genuine addiction. But even the studies about this sometimes mix up the terms addiction and dependence. So it's really hard to figure out. But what appears to be the case is for people in pain who use the drugs medically, not non-medically, and who have no family history of substance abuse, the rate of genuine addiction is probably less than 1%. So it really depends on who's taking them and for what reason and how responsibly or irresponsibly they're taking them.
Judy, I'm wondering about chronic pain and how often it happens that it's not treated adequately.
I would say all the time. We do have an overtreatment problem with people getting opioids for minor things like a tooth extraction or a root canal or a basal cell carcinoma removal, where you really do not need opioids. I mean, some doctors just willy-nilly prescribe this stuff. But the far bigger problem is people who really need the opioids not being able to get them. The government is cracking down a lot, and doctors are terrified to give them because they don't really know how to use the opioids. It goes back to that lack of medical education about pain and treatments of pain. So it can be an enormous burden for patients to have to physically go to the doctor to get a physical prescription, to take it to the pharmacy, to wait in line. A lot of people, the pharmacies sometimes are calling the doctor to verify that this is really necessary. There's a lot of paperwork and hassle involved in patients with severe pain trying to get to the doctor. Many of these people can't walk or drive. Some of them can barely get off the couch. It really, there are big obstacles in the way for people who really, really do need the opioids. And that's, in my mind, unforgivable. I mean, there are medical ethicists who think that the failure to treat pain better is tantamount to torture by omission. And to that extent, we are kind of torturing people who really do need the opioids and who use them responsibly. And that's wrong. We're sort of throwing out the baby with the bathwater on that one.
Well, in point of fact, the DEA has recently, I think, changed access and to a certain extent the law in terms of access to, I guess is it hydrocodone, whereas
Yes.
before people used to be able to get up to 6 prescriptions. Now they
Right.
have to go in each month to get a renewal. And their
That's
doctor
right.
can't phone it in, can't fax it in. There are real barriers for people who are in severe pain.
That's exactly right. And that's not fair. That's really punishing legitimate pain patients because of the behavior of people who take the drugs non-medically. I mean, that's just sort of not fair.
Judy, you mentioned that cancer patients, especially patients who are at the end of their lives, are sometimes, if not often, undertreated for pain. Why do you think that is?
I wish I knew, but there's an appalling figure that even the most recent studies show that 1/3 of people in hospice, and most of those are in hospice because of cancer, are dying in pain. That's absurd. These risks, even of dependence, let alone addiction, are really not relevant by the time someone is in pain. I think it's the stigma, and I think some doctors are not aware of how to prescribe these things. And to me, that's just a travesty. People are dying in pain when they don't need to be. And I think it's just thinking hasn't evolved as it should have. I mean, we're still kind of back in the dark ages on this.
You're listening to Judy Foreman. She's a nationally syndicated health columnist. Her book is A Nation in Pain, Healing Our Biggest Health Problem.
And we'd like to hear from you. Share your own experience with opioid pain relievers at peoplespharmacy.com.
It is time for us to take a short break. Coming up, we'll talk about pain relief other than opioids.
What else can be done for chronic pain?
Are there differences between men and women when it comes to pain and pain medication?
And how do you get doctors on board with alternative treatment modalities? Could marijuana have a role in treating chronic pain?
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. The number, 345-7339. The website is uttercream.com.
And by Squatty Potty, the original toilet footstool that creates healthy toilet posture. You can learn how squatting relaxes the colon and allows for easier, healthier elimination at squattypotty.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1021. That number again, 800-732-2334. Online at peoplespharmacy.com.
Our topic today is chronic pain. 100 million Americans suffer with it.
We're talking with Judy Foreman. She's a nationally syndicated health columnist who spent 23 years as a staff writer for the Boston Globe. She's a senior fellow at the Schuster Institute for Investigative Journalism at Brandeis and author of A Nation in Pain, Healing Our Biggest Health Problem.
Judy, you've mentioned that although opioids can certainly be helpful, they're not by no means the whole story. Can you tell us what can people do to control severe chronic pain?
Well, the American Chronic Pain Association, which is a great resource for people, and the website is, you can find it by that name, it talks about doing everything. You know, we've talked about the alternative things, acupuncture, massage, chiropractic, all those things. We've talked about the drugs, the over-the-counter drugs, and the opioids. There are surgical interventions that, I would hardly recommend not leaping to surgery, like for back problems, unless that really is warranted, because many times it doesn't work. It can just sort of move the pain up or down the spine a level or create what's called failed back syndrome. So when surgery works and is necessary, it's great, but, second opinions or third opinions are really important for that. There are various things like electrical stimulation, implanting electrodes in or near the spine that kind of swamp the brain with white noise kind of signals that essentially dampen out the brain's ability to respond to incoming signals as pain. That can help. Meditation, I don't know if you want to go to non-medical intervention,
Absolutely.
but meditation, first of all, meditators, long-term meditators tend to get less pain in the first place. Meditation can be very helpful in reducing the stress associated with pain because, as we said at the very beginning, pain is an emotional as well as a sensory experience. And people can reduce their pain somewhat by meditation, and it's free once you learn how to do it. I mean, you can go to some classes and learn. You can do it on your own. You can do it any time of day or night. Like everything else, including surgery, it's not a slam dunk, but if it can knock your pain down one notch on the pain scale and you're doing other things too, it's another tool in your armamentarium. Hypnosis can work. Distraction is very interesting. There's some studies showing that if they put people in kind of like a virtual reality room with goggles and joysticks and stuff, they can, by distracting the brain from a painful procedure like a debridement of a burn, the pain can be, your brain is not paying attention to the brain if you're doing a virtual reality, like testing something, like playing video games, fancy video games. So there's lots of things like that can help. There's also some very interesting studies from Stanford by a prominent pain researcher named Sean Mackey, who put people in fMRI machines. These are functional magnetic resonance imaging machines. And these were different people, some with experimentally induced pain and some with real life pain. And they had real-time fMRI. So the people are in the machine looking at a screen, which is showing what their brain is doing. And then they did tricks like cognitive behavior therapy or distraction. And they were able to see on the screen that as they focused their mind on something else, the pain centers in the brain and the emotional centers in the brain got less active. So they were it was really neurofeedback. They were training themselves to focus less on the pain. So I think distraction is great. But sometimes you cannot get rid of all the pain. I mean, I know among the people I interviewed for this book, people whose pain is not gone, but they are managing it well enough that they can live their lives. And it takes work. An old woman I know had a bunch of filing cabinets fall on her back about 15 years ago, and she has had constant back pain for 15 years. She is no longer taking opioids, does take some other medications when she needs to, but basically she cannot sit or stand for more than an hour at a time. So she arranges her life. So she gives talks all over the place, goes to meetings, the big pain patient advocate now. She'll give a talk, go lie down in the corner of the room. She'll buy plane tickets, 2 seats, lies down across a seat. She goes to the Boston Symphony Orchestra and lies down on the floor during intermission. She arranges her life, does a lot of exercise. She does a lot of things to manage her pain. I watched her run a pain patient support group from the floor. So it's not anybody's ideal way to live, but with effort, you can manage. And I mean, not everyone has her guts, but people can do it. People can manage incredibly well, even though the pain doesn't totally go away.
Are there differences between men and women when it comes to pain and when it comes to pain medication?
Oh, wow. Yes. Yes and yes. Women get a disproportionate share of the pain conditions that could affect either sex. So we're not talking about childbirth or even breast cancer or pelvic inflammatory disease, but things like cancer, fibromyalgia, irritable bowel, migraines. Women get much more than men. It's much more prevalent in women, and the pain is often more severe. Nobody really knows why. It may be partly cultural, but there do seem to be important hormonal differences in the way men and women process pain. And in general, testosterone, which is more prominent in men, obviously, seems to protect against pain, and estrogen is all over the place. Sometimes pain is worse for women when in their menstrual cycle or in their life cycle when estrogen is high. Sometimes it's worse when estrogen is low. It really varies, which makes it really tough to figure out. But yes, big differences. Differences by sex in terms of how well people respond to pain medications. I mean, there's a wonderful geneticist at McGill, Jeff Mogul, who thinks that someday we will have pink pills for women and blue pills for men because the opioids have such different effects in the two different sexes. And there was even a study a few years ago in Italy, a kind of a preliminary study on transsexuals. And when the people went from male to female and began taking estrogen, their chronic pain conditions got worse. And when they went the other way from female to male and started taking testosterone, their pain got better. So there does seem to be, a pretty big hormonal influence. It's just that it's very tough to figure out.
What about kids? I think there was a time when doctors didn't really think kids experience pain quite the same way adults did, especially babies. And that brings up the whole controversy about pain during circumcision.
Yes. It's unfathomable to me. But until, 10 or 20 years ago, doctors thought that kids didn't feel pain, or that if they did feel pain, they wouldn't remember it. And that's not true. And just as a parenthetical point, because I've just been writing about this now, many people think the same thing of blacks, that blacks don't feel pain as much as whites, or Hispanics don't feel pain as much as whites. I mean, we have these beliefs about others, kids or someone of a different color. And it's completely nuts. But yes, kids were, especially babies, were thought to not feel pain. And there are some horrendous examples of babies undergoing surgery without anesthesia and, just basically suffering tremendously. And that belief, I think, is slowly changing. And part of what underlay that belief was that doctors didn't know how to use anesthesia in very, very tiny babies. They've gotten a lot better at that. So that is a good thing. But still, that recognition that kids do feel a lot of pain has not penetrated all the hospitals. And for things like you mentioned, like circumcision, it turns out that kids who've been circumcised without any anesthesia, they're more sensitive subsequently to injections or any kind of painful procedure. Their brains remember that. So it's completely untrue that kids don't feel pain. They do. And we tend to under-medicate kids compared to medicating adults, and yet their pain is just as worth paying attention to.
Judy, we've been talking about alternative pain approaches. You mentioned chiropractic and acupuncture and meditation and massage and hypnosis. And there are a lot of physicians who say, I didn't learn much about that in medical school. I think it's all hocus pocus. How do we bring our doctors onto the team to accept and appreciate some of these other ways of dealing with pain?
Boy, if I had the answer to that, I'd get a Nobel Prize. I really think that it's several problems. The reimbursement for these things is all cockeyed. I mean, we pay doctors for doing procedures like injections and not for talking to patients. We reimburse them for 7 minutes or 15 or whatever it is for a patient instead of half an hour or more. I mean, what we are willing to pay for through the government and through private insurance is often the wrong thing. So the reimbursement system is a big part of the problem. I think it's going to take patient activism to get doctors to start paying more attention to this. The other thing is medical schools really have a long way to go. As we've already mentioned, they barely teach pain at all and also barely teach any of these other things. So I think there are ways forward, but it's going to take a lot of political action, unfortunately, especially by patients. I mean, I've been a journalist for 40-some years now, and I've watched people with disabilities and breast cancer and AIDS really get rid of their shame and isolation and stigma and literally take to the streets, go on television, write letters to the editor, go to Congress and say, pay attention to our problem. And I think ultimately it will depend on pain patients doing the same thing to get it on the radar screen for people.
Judy, what about the role of marijuana? We understand that there are a lot of people who are smoking marijuana, are using cannabinoids, are using tetrahydrocannabinol in particular. There's even something that you can buy legitimately as a prescription drug called Marinol. Does marijuana actually have a role to play in pain?
Absolutely. It's there have been some studies suggesting that marijuana or cannabis was the preferred term can reduce pain by about a third, which is basically what opioids do. There's also some data suggesting that if you use marijuana and opioids, you can reduce the amount of opioids that you take. There seems to be a positive synergistic effect. Marijuana is quite a safe drug compared to the other things that people take. It's much less addictive than tobacco. I mean, according to the National Institute on Drug Abuse, tobacco, 30+% of people who smoke get addicted. Heroin is 23%, cocaine 17%, alcohol 15%, marijuana is only 9%. So it has much less abuse potential in that way. There are some concerns for adolescents for taking it, people with developing brains. There is some concern about schizophrenia and also some cognitive problems. But that data is there's mixed data on that. For people who use it for pain relief, it can be very good. I'm really heartened by the growing movement toward legalization of marijuana because it is a much safer drug than many of the other choices. And interestingly, what it seems to do is reduce the person's emotional reactivity to the pain. I had one woman with trigeminal neuralgia tell me she takes a puff and doesn't take a whole joint. It just, one puff or two. People titrate themselves pretty well. One puff and she feels as though the pain steps a foot off her face. It's still there. She knows it's still there, but she's not as engaged with it emotionally. And that's a very helpful thing. Incidentally, that seems to be what happens with meditation, is that you can sort of reduce the emotional reactivity to the pain, not necessarily the sensory part. So I think it's great that you asked about marijuana because that should be part of the debate. And I think it can be very helpful. And I think the train is going that way regardless of what you and I think.
Judy, how much money is being spent on pain research?
Almost nothing. That's a great question. The NIH spends less than 1% of its massive budget on basic research into pain, even though, as we know, pain is the main reason people go to doctors, and it's the main reason that Americans are on disability. So it's a huge problem. And it's also an interesting problem. I mean, it's basic neurobiology, and it's, from a science writer's point of view, it's really interesting. It's worth studying just intellectually, but it's mainly important to study for the clinical applications, and we're just not doing it, which baffles me because Congress must have pain. They certainly cause pain. They must have pain just like the rest of us. So definitely we need a lot more commitment to the budget. I mean, some people, including me, think that there should be an institute for the study of pain at NIH, the way there are institutes within the NIH for just about every other disease. And chronic pain is a disease in its own right. So I think it deserves an institute of its own.
What should our listeners take away from your research into this topic?
That if someone tells you they have pain, believe them. Don't let your assumption be that they're faking or drug seeking. Believe them first. But also tell them, it's hard if you haven't experienced to believe them, and you can't experience their experience, but to take it seriously, to realize that people who are in legitimate pain do need access to opioids that isn't too much of a hassle, that people with the disease of addiction really do need better treatment, more availability of naloxone, which counteracts potential overdoses. We need many more treatment centers for people with addiction problems. And we basically need what the Institute of Medicine report said is a cultural transformation. Chronic pain has to get on the national radar screen. And so far it's not, but it could be because, disability, AIDS, breast cancer, that didn't used to be on our national radar screen, and it is now. And it's because of patient activism, which could hold true for pain too.
Judy Foreman, thank you very much for talking with us on the People's Pharmacy today.
Thank you. I enjoyed it.
You've been listening to nationally syndicated health writer Judy Foreman. She's a senior fellow at the Schuster Institute for Investigative Journalism at Brandeis and author of the book A Nation in Pain, Healing Our Biggest Health Problem. Her website is judyforeman.com. There's a link to it from our website.
Lynn Siegel produced today's show. Russ Henry and Al Wadarsky are the engineers. Dave Graydon edits our interviews. The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC. The People's Pharmacy theme music is by B.J. Liederman. The People's Pharmacy is made possible by Red X Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. The number is 800-345-7339. The website is uttercream.com. If you would like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1021. That number again, 800-732-2334, or find it online at peoplespharmacy.com. When you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your own experiences and thoughts on today's show and the new DEA regulation on opioids. When you go to the website, you can also sign up for our free online newsletter or the free podcast of the show. You need never miss another People's Pharmacy program, and you can share it with a friend. It's there at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon. And I'm Terry Graydon. Thank you for listening, and please join us again next week when we talk with Dr. Taroni Lodog about dietary supplements. Her new book is Fortify Your Life. We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.